Okay, guys, what do you guys can tell me about EMS research, or what do you think it means? Why do you think it's important?
The study of all the treatments that we do.
Okay.
Things like that.
So it's not just why we do something.
Huh?
Allows you to determine the effectiveness of its
Effectiveness. Okay.
I think of EMS in general, in the medical field, is such a new aspect of it. I mean, there's not a lot of things that they've been doing in hospitals for a while hadn't quite been implemented in EMS yet. Research to see if it works as far as improving patient outcomes.
No, you're right. Yeah,
And then when
absolutely.
they do perform research and then they find out we can do stuff to improve it, then we get new equipment.
So yeah,
That's all from research.
yeah. Thing is, yeah, we get new toys. That's one way of looking. New toys, new drugs. We got to try them out. Does it work? Does it seem like a good idea? Does this mean it's a good idea? Does it mean it's going to be an actual applicable idea? Right? That's a big difference there too. I mean, you guys ever heard of the geezer squeezer? The actual rep band. It actually looks like a mini boogie board. It has a big band. It actually gives circumferential pressure for compressions. Yeah. I remember when they were testing that down in Austin, and the only thing they came up with was like, yeah, it leaves you warm and dead. Or it leaves you pink and dead. What did it really do? Did it actually really help? Did it really solve anything at that point? Again, good idea, but let's see how it really works in reality.
Well, how do you test it out? So I don't like.
Well, somebody's got to die. That's the
Well,
first
I know,
thing.
but like, it's like, how do you have their consent? Hey, you want to just look this?
I mean, how do they not have legal or
That's EMS has a loophole. To be honest, we'll talk a little bit about that, but EMS has a loophole on that one. So anyway, the idea of research, our little quest for knowledge. Who is Hippocrates? Hippocrates, rather. Sorry.
from like Athens? He was like an early patient advocate, or
yeah, he's pretty much this is kind of the beginning of our medical schools, really. All the different Greek schools that were going on during the time, and obviously with Socrates, and who's the other one? Archimedes was another one. But yeah, that was one of the schools that was geared towards medicine. So, by the way, why willow bark? Anybody know what's made? We make from it? Aspirin. Yeah.
Actually, I did read that the other day.
Yeah, chewing willow bark is aspirin. So then we go down to the 18th century here. Then all of a sudden it's like, wait a minute. We found this plant called purple foxglove, and it was actually helping.
Sounds like a rock band.
Yeah. Old 70s rock band. Well, the thing is, it wasn't just just people that were sick and dying, but it was people that were having heart problems and breathing problems. So, you guys have any idea? Take a stab. What drug came from that?
Killed those who were healthy.
Huh?
I don't know.
Yeah, it does. Yeah, and this drug will do the same thing to you. If you're healthy, it will kill you. You guys heard of digitalis? Yeah, that's where this one comes from. But yeah, these people that were having chest issues, and obviously if digitalis is a drug, what it actually. How many of you guys are familiar with your sodium potassium pumps, your ATP pumps? Yes, no. Okay. Basically, we have for the cell to contract, we have to have a big influx of sodium, and then we have to kick out the potassium. Then have to kind of repeat the cycle, kind of a thing. And then, like I said, faster we can get that cycle, faster it goes, right? Well, what digitalis does, it actually inhibits those pumps, so you don't have the fast rate, okay, but you have the strong contractility. The only thing is left is the calcium to really give you a good, strong contractility in your heart. So obviously with somebody who has like an AFib with rapid ventricular response, it's going too fast, good drug, right? Okay, what about somebody who has CHF? Good contractility. See, so that's the thing they kind of started identifying. What about, anybody heard of was it belladonna? Ever heard of that plant? Yeah. Yeah, there's actually another drug that we use quite often that came from belladonna, that we still use. You guys heard of atropine? You guys remember your sympathetic nervous system? Atropine pretty much says you're not going to have your parasympathetic isn't going to work. We're going to block all that for you. So the only thing you have is your sympathetic side going. We used to give atropine all the time in cardiac arrest. Now we just give it for primarily for bradycardia. So your heart rate's low. We don't want to, douse you with a bunch of, epinephrine or adrenaline. Well, what if we just take one piece out of the equation and then let, the sympathetic go uninhibited at its normal rate?
So just pretty much like inhibit your natural epinephrine without synthetic.
Actually,
epinephrine.
it inhibits acetylcholine, the neurotransmitter for it. And that's, we'll talk a lot about that once you get into pathophysiology, especially pharmacology. But one thing I'll tell you, you'll notice about with body and drugs, either we're trying to inhibit a response or we're trying to stimulate a response. We can't seem to do one or the other. So here's the problem. Okay, EMS activities are based on tradition, just like any other. I remember years ago when I was a firefighter. 200 years of tradition that has impeded progress. We do the same thing. This is the way we always did it. Or, kind of give you some examples. Like I was telling you before, like system status management that came about. There's nothing to back it up, but a lot of places do it. Well, it's just the way it's always done. It sounded like a good idea. I think of other little traditions. We used to give a lot of IV boluses to people that probably were actually normotensive, but we thought it's like, well, it's from what we're saying, even though you just had a trauma issue or this and the other, we're going to give you a bolus anywhere. Actually, a good one actually was cardiac arrest. We used to always give boluses all the time. Person's in cardiac arrest and not bleeding out. Was there a blood loss?
No.
Yeah, but that was the thing. Well, let's just give them a bolus and see if we can, up the pressure. It's like, that's not the problem. Fluid in there is fine. We're not trying to replace. But again, those are little things that we did. We just did them. It was just the way it was. In fact, kind of an interesting little tradition. You guys, for example, what is it on bradycardias for children? What is it if the heart rate's less than 60? What do we do?
Make them.
What? Chest compressions.
Or children.
Huh? Yeah, different children. Less than 60, we give them chest compressions, right? Okay, what's the other thing now? What is it when we convert back to a normal sinus rhythm and we start feeling a pulse? What do we do now? We're actually supposed to do another 2 minutes of compressions. But the big thing was we never want to do compressions on a beating heart because we're like, we were under this taboo of an adult heart can't handle this, but a child's heart could. So you guys understand why we're actually supposed to give compressions afterwards when we start getting a pulse back? Yes, no? Huh? You do?
Yeah.
Why?
Because even though we got it up to where it was after we stopped, there's the possibility of it dropping. But if we continue it at the rate that it's at, that we want it at, then...
Yes and no.
Okay.
Yes and no. Here's the problem. I die right now. Okay? Everything stops. What happens to my vasculature? Huh?
Starts the constricts.
If I'm dead?
Oh no, dilate.
Dilate, right? You get me back. How long is it going to take for that constriction to finally catch up? Because I got to circulate blood to get all this going around, right? So I've got this weak heart. It's trying to build pressure. If you think of like if I actually had one, a blood pressure cuff.
Kind of sitting here and pumping all this time and nothing's happening.
Yeah, when we build a pressure, we pump, and everything's nice and inflated, right? Well, I turn it off or I stop, all that air deflates. So now I start pumping again. Look how long it takes to build up that pressure. We're trying to get that peripheral pressure. That's why we're saying let's do another 2 minutes of CPR because we want to help that heart start creating that, push and get that more pressure there. Does that make sense?
Yeah.
But that's the thing that we had this, taboo of. Well, understand we could do with, cardiac and with child we could do compressions, but no, we couldn't do that with an adult. Adults' hearts are too frail. No, actually, it can handle it just fine. So anyway, we came to this thing of we needed to move towards evidence-based EMS practice. You're going to hear that term, and actually, it's kind of funny. This is interesting. Anything that's evidence-based actually started with the medical community. We want to do evidence-based medicine. You'll hear that. There's actually other professions that have taken that whole evidence-based term. For example, like evidence-based human resources. I'm not kidding on this one. I took a class on it. But yeah, they're like, we have evidence-based human resources, saying not what we're doing is doing, but it actually works. So we started going to stance of like, well, let's try and justify it and saying what it is we're doing. A lot of the drugs that we give, for example, in cardiac arrest, there's actually one that actually really is shown to work. The other ones, we have just kind of gone off theory. And now we're actually going back to, well, we actually really ought to study this. Amiodarone is the only one that's really been tested. Now they're actually starting to test, amiodarone to lidocaine to procainamide, other drugs that were given in cardiac arrest. Otherwise, it was just kind of like, well, it sounds good in theory, we'll kind of work it, or we saw this results, but we don't know what drug was really doing what. Another one that actually looking into right now is epinephrine. Okay, epinephrine is always the first round drug in a cardiac arrest. Well, we've never really touched the taboo of epinephrine because epinephrine, when you give it to it, it increases contractility. It can actually cause vasoconstriction. Can cause increased heart rate and so forth, so forth. So how is that applicable when you're dead? If there's nothing going on, how can we stimulate it, right? That's
So is the theory that once you start CPR, that if you're dead and the vessels are dilated, that once you give that drug and you start CPR, that it's going to help constrict and make the heart go faster?
Yeah, we're trying to stimulate the heart.
Like the theory of?
Yeah.
It's
Classic paramedic question. I used to show up on tests, why do we give epinephrine in a cardiac arrest? Vasoconstriction. We have more vasoconstriction, we start doing compressions, we start having higher systemic pressure, tissue gets perfused, kind of a thing. But Thailand, of all places, is actually studying with epinephrine, without epinephrine. Right now they're showing it doesn't make a difference. But again, things that we just said, well, wait a minute, it makes sense. It does this stuff when you're alive. I mean, you give epinephrine to yourself, I mean, it'll light you up like a Christmas tree. We give, especially, you guys familiar with the different concentrations of epinephrine by chance? When you guys, 1,000. You have 1 milligram in, basically 1 milligram in 10 cc's and 1 milligram in 1 cc. 1 to 10 usually you give intravenously. I actually remember talking to a doctor one time. He's like, yeah, I remember one time I made the mistake of giving a 1 to 1,000, intravenously. Think about, that whole Kool-Aid in the pitcher thing. If I put the full, pitcher of water, everything turns out, tastes okay. But if I only put a couple cups, how rich it is. Yeah, he said the guy about flew off the table on him. So, but again, like I said, it's evidence-based practice is what we're doing effective. In fact, if anything that's ever been shown with CPR or cardiac arrest, two things that work the best are electricity and compressions. They'll stress more about that than worrying about the drugs. As long as you get the electricity and compressions down the road, we can work around everything else. So, the other one was movement towards professionalism. Okay, like I think I told you before, it's like I remember the day where we'd be walking, you'd see medics walking around, they got their cigarettes hanging, behind their ear. A lot of times, I can think of shirts being buttoned down to here. I think part of that was kind of generational, though. You laugh now. Yeah, it was pretty interesting. I could tell you some other stories, but I don't. So anyway, it moves towards standards of care. Ideally, that's kind of our, a nice way of saying, protocols, but we want to sit there and say, okay, we really want to be on the same page with everybody for the most part. We don't want to kind of stand out and go against the grain per se. You start going against the grain, you'd actually kind of put yourself more in a, actually kind of put you more of a target. And kind of give you an example, when you talk about, like, for example, like a standard of care, if everybody here runs into that CHF patient, we all know we're going to be on the same page of how to treat that CHF patient. Not one person can sit there and say, well, I still found a bunch of DID from the last cardiac arrest patient. Here, take some of these and see what happens. Kind of want to avoid things like that. The other aspect of having more of a standardization is one thing we kind of ran into is like RSI, and you guys will talk about RSI here in a few more weeks. Rapid sequence intubation. Like when I did RSI first, the way we were doing RSI before it really got to kind of took off. I mean, we used to snow these people out with a bunch of morphine and Valium. We just hit them hard, okay, take them and intubate them. Now, when we go through it in here, I mean, and you're going to see out there, it's actually a very structured event. We make sure we have paralytics, we make sure we have, an induction agent, and, we make sure we got everything ready, and everything is a big, prep work, and boom, drugs drop, boom, we're dropping tube, we secure the tube, we verify the tube's good, and so forth, and we kind of move on. Standing out like thing, my RSI versus your RSI may be different. No, we kind of want to be on the same page with everybody on this portion. You don't want to sit there and go. We might have different paralytics, but we still want to be on the process of yes, we are using an induction agent. Yes, we're using a paralytic versus, like I said years ago. Hey, can I get this person's about to drop? Can I get some morphine and Valium so I can tube them? Yeah, sure. That's really what it was. So, what about a unique body of knowledge? What's unique about us?
So non-controlled environment.
Yeah, it's a very public safety is not safe. Always love that quote. That's if you guys ever run into Joe Granberry, he's a assistant director over at Williamson County. He's actually also my division commander over at Austin. But he's got about 30 some odd years of this, and he'll tell you public safety is not safe. So we have to have a certain knowledge to deal with what it is we're dealing out here. How a nurse deals something on the medical unit is going to be a very different set of knowledge and skills versus what we're doing. So, advancement in the field. You guys know what's going on with this.
More skills that we can do, that they allow us.
Yeah, critical care paramedics, one that showed up about almost 15 years ago, but has not actually caught a lot of popularity probably until about the last 7. There's a lot of big push right now for making a community practice paramedic or advanced practice paramedic. That's one that's, they've been playing with for about the last 3-4 years.
What is all that? What would the difference as far as?
Well, it's more of a solution to problems is really what it is. And what the idea is, okay, we get a lot of these people that have indigent care, use the ER for primary care, or maybe these people are discharged and they're back in the hospitals. So how can we stop all these unnecessary ER visits and all these unnecessary ambulance calls if we have somebody out there sit there and say, okay, I'm going to come out, I'm going to talk to you, I'm going to check you out, and say, okay, well, wait a minute here. I'm going to call the clinic, I'm going to schedule an appointment, here's a bottle of amoxicillin to start taking now, but you're going to follow up there, we don't need to get you in the ER. We're trying to take that unnecessariness. It's kind of a mix between family practice medicine and social work, because then now we're dealing, actually I just met with Andy Hoffmeister down in Austin. He does a lot of that. He's working on a lot of that right now, and he's dealing with a lot of the substance abusers, the psych patients that getting the routine calls and say, well, why don't we get them to the people they need to be talking to instead of to the ER where they're taking up, and then we're trying to figure out what to do with them. So, Webster defines as to search. What is research? To search, to examine with continued care and seek diligently, to search again and to examine anew. Diligent inquiry or examination in seeking facts or principles, laborious or continued search after truth as research of human wisdom. Big thing to understand here, research is a continual process. Even when we, I think you'll probably run into some of the things in your journals there. It's like, yeah, this was tried several times. This study proved results. This group didn't prove results, and this one was kind of so. So we try to sit there and say, well, what is something workable or applicable or seems to be consistent out of all this? Or you'll see a lot of research kind of built off other research projects, which is very, very normal. So research is what I am doing when I don't know what I am doing. I'm trying to figure this out. How do I get around it? So this begins at birth. First thing, what do babies do? They're touching things, they're looking at things, they're getting into things, they're putting things in their mouth. Okay, how does a 2-year-old test your limits? So very similar to how students test a paramedic instructor's limits.
Oh,
Ouch.
we haven't thrown any tantrums yet.
Huh?
We haven't
Yet.
thrown any tantrums
Yet.
yet.
I know, you said yet.
Well,
So but look at the thing is, it's like, how do I test? How am I testing boundaries? How far can I go? Actually, it probably gets worse in your teenage years, but how much? Yeah, exactly. So, why did the light bulb not come on? I don't know. Or maybe if you're my cat, trying to figure out how to turn on the light. That's another one that's Neil's cat actually has been trying to figure that out. He's been, we have little interesting cat talks every now and then. So anyway, the point is that I'll leave it alone. EMS does weird things to you guys. Okay, I've been doing this a long time. You get a little weird after a while. Anyway, explore, discover, and learn is the whole point of all this. So here's the fun part. There's virtually no aspect of EMS that could meet the current requirements of FDA approval as a safe and effective new therapy. That's the problem that we're running into. So we got to figure out how do we do this. I think a lot of it's kind of starting to change because some of them, obviously, we're getting a little bit more FDA approval and say, okay, wait, this actually does work. And to kind of answer a question earlier, it's like, well, how do we test things on people? A lot of times when they do drug research, you go voluntarily. You go voluntarily. Either one, you're just kind of the straight up, guinea pig that's coming in for your, these people. I've heard these people make like $2,000 a month. Just going in, trusting drugs for a weekend and go home, and then follow up a couple times.
If they alive.
Huh?
If they stay alive.
Yeah, how much can your liver take, kind of a deal. Then, unless you actually have the actual disease itself, you can volunteer for, opt for these therapy. The thing that we get around is that we can sit there and say, well, obviously an emergency procedure, we can drop this drug and see if we get results. Obviously, that was a big thing with amiodarone because we can't get consent; they get already dead. So we're kind of saying, well, this could be very much work in their best interest, and that's how we get around that.
So it's almost like a what do you call it? Student consent, or
Yeah, it's
implied consent.
implied consent. Well, the thing is, it's always just like, what about, we want to try like a different type of antihistamine, and their person is semi-conscious. Do we ask them? If we're going to anaphylactic, hey, we can just drop it and ask questions later. But if I'm having a mild allergic reaction, or the patient is, do we try to deal with that whole paperwork scheme, or do we drop now and justify and say this could turn into a situation, therefore we used it, and then back it up with Benadryl later? We kind of really go. We're in a very gray area with this. So anyway, emergency medicine. If it sounded reasonable, it was included in teaching. The kind of interesting thing about creating things, especially in talking about community paramedic and stuff, we know what the problems are. So how do we put this together? They ran into the same thing with EMS how many odd years ago. Okay, how do we put this together? We know we've got these problems, so what do we give them to do this? And like I said before, it could actually vary between physician to place because there wasn't no standardization. It's like, well, I think this would work here, and this physician may disagree and say we're going to teach this skill set. So that's the hardest thing, I think, is to sit there and say, well, we know what we're trying to solve, but how do we create this, being to take care of this with the appropriate skill sets and knowledge? So, proven practices. Mask pants. We teach you. We talk about it. You'll probably never use them. Now, again, interesting conversation between me and Neil. He'll swear up and down that these things work, and they really do work. I will totally, completely disagree with them. The only justifiable evidence I ever found for these things is if you had a pressure of like less than 50, then yes, we actually saw a positive result. But if you have a pressure of less than 50, you've got a lot of other problems in life. They try to say, hold on, let's get these little moon pants on you. Everything else has been considered saying there's nothing. Do you guys know the history behind this?
what, pilots?
Yeah, pilots. Yeah, it's what fighter pilots use this because they want their blood rushing out of them at G-forces. It's like, well, the same again. It sounds like a good idea. We keep the blood, in the core of the body. It works for a pilot. Why can't it work for somebody in a traumatic situation or going into shock? So, Epicac. You guys are familiar with Epicac? Yeah. That's.
That's the stuff that makes you vomit, right?
Yeah.
If you ingest something.
Yeah, it's precursor was castor oil. It really is. Yeah. It's like, well, either one, you can punish your kids with castor oil, or your kid's sick, or just give them castor oil, throw them up. Okay. The other thing is fluid challenges. Again, that's what's kind of like telling you about the whole cardiac arrest thing. Hey, what do we give him a fluid challenge? See what happens. Probably ain't gonna hurt. He's already dead, but it probably ain't gonna help either. So why are we doing it? So anyway, why is it important? We want to establish a standard of care. We want to make sure to say, hey, this, we know across the board that this stuff works, right? We don't want to have to worry about this is too different, for place to place. It's like, okay, we know things are working. We're going to make sure it gets around to the rest of the country. So we're all doing things that are working, and people's lives get saved and all that business. The other part is evaluate dogmas. Again, that comes back, well, this is kind of the way we did it. That's just what we did. Well, just because we thought it was a good idea and kept doing it, does it really mean it's worth anything? So develop a own scientific basis. EMS has been kind of the redheaded stepchild in medicine for a very, very long time. It's just kind of like, really, what we developed out of Vietnam vets that end up turning into ambulance drivers. And that's what a lot of that stuff was. I mean, it was like, or the morgue, had this little, car to take dead bodies. Oh, wait a minute, somebody go take you from point A to point B, put the little red light on, there's your ambulance. Doesn't mean anybody was back there. So, evaluate the latest gadget or finding. Again, we come up, with little things like the geyser squeezer. Is it really useful? Is it not? So, and the thing is, are we making a difference? I mean, ideally, we want to be making a difference, because we don't make a difference, we're costing somebody money somewhere. And that's one of those necessary evils we don't like to talk about, but if we're not making a difference and we're spending lots of money, guess what usually happens? Unless you're a government agency, you're getting cut. So why should you get involved? Research, I'm going to tell you this much. When you're at that point where you're really interested in getting research. Don't get into research because we need, if you're not interested, don't do it, kind of a thing. But the point is perform day-to-day activities. The whole point is identifying problems, finding solutions. That's a lot of what we're doing. So, and understand and appreciate its value. Okay, a lot of us are not researchers. We're just not that kind of person, or maybe you're not that person yet. But like I said, we do need those people that can sit, crunch numbers, and come up with all the hypotheses and build out all those studies. If you ever want, Jarvis loves research. Jarvis likes putting up research projects. So me, on the other hand, it's kind of like, it's nice to hear about, talk about, but what's on YouTube? So, and again, sorry guys, I'll admit my flaws openly. So, and understand, I'll understand its importance. Like I said, research helps us progress. Let's take a break right here. All right, approach to research, quantitative versus qualitative. Big thing with quantitative, just remember it's quantity. There's usually a number attached behind it versus quality. Obviously this can be, let's say less objective, less precise, and just not easily measured, but just remember the two. So I could talk about different red-green hats, different types of red-green hats. That's more of a qualitative versus actual talk about the number that I'm getting the quantitative. All right there, John?
Yeah, I'm good. I rolled my ankle today, it's starting to swell.
Okay.
Yeah, I'm good.
The other thing is perspective versus retrospective. What's the difference?
One's like beforehand, one's after.
Yeah. Ideally, you want research to be perspective, going forward, kind of figuring out as we're going along. The retrospective is kind of easier because, we're just looking back what's already there. And it's usually, a lot of people do this by, well, I'll get to that in a minute. Anyway, perspective, like I said, we pretty much sit there and say, well, we're going to find out if, tourniquets actually work in the EMS environment. So, okay, so we sit there and say we're going to give out these types of tourniquets, and then we're going to sit there and say, okay, well, if we're in situations that we're going to evaluate, did it actually stop the bleeding, and then afterwards, what was the actual tissue perfusion afterwards for applying the tourniquet. This is real stuff, but you guys know we use tourniquets in the field now. So yeah, things, ironic things, a lot of times we kind of bounce off of like what the military is doing, because they're a little bit more, I don't know, civilian versus military, they've got a lot more freedom than we do to do these things and not have to be questioned as much, and versus us, we got so much bureaucracy and people getting upset. But yeah, that was one of the things they found out. Is like, yeah, you put a tourniquet on somebody and they can sit up to almost like 3 hours or something. Is that right?
They told us 6 hours.
6 hours, yeah. We were always worried about, you put a tourniquet on somebody, it's going to cut circulation, their limb's going to be acidotic, and they're going to, by the time you pull that tourniquet off, that limb is going to be completely useless and be so acidotic, so we're going to put them into rhabdo and kidney failure, And they're finding out, oh no, actually they can stay on quite a long time. So again, even putting into the civilian world, we got to sit there and study and say, okay, is it really helpful? Even though most of the time we're, 20 minutes, 30 minutes? So, disadvantage, obviously it takes a long time to complete, depending on what it is you're trying to do and what it is you're trying to find. And of course, we can always have a little bit of, any kind of research always can have a little bit of a bias. You want to think, obviously if you're the one heading the research, you want to go in your direction, I hope, right? Retrospective, pretty much all we're doing is we're looking back at what's already happened. Did we find any trends? Did we find any problems? A lot of clinical managers will do this, a lot of retrospective. They'll sit there and say, okay, well, how much of our people in our system are getting first-time intubations? And they'll just kind of run the numbers. Okay, how many people are successful second time? You know, they'll do the same things with IVs, but people have been doing it. Now they can sit there and look back and say, is there a problem? Is there not a problem? And so forth. So, and that's kind of the advantage there, because everything's all there. You just got to crunch numbers. So disadvantages, data collected for other reasons. You know, why are we really doing this? And something may not be documented. Like I said, it's trying to isolate different events or pieces of information. You know, for example, like with the innovations, we could sit there and say, yeah, everybody in this row cannot do a first-time innovation versus everybody back here can do a first-time innovations. Well, we never discuss what circumstances these guys are running into. These guys could have been all, you know, in some nice house, you know, or a nice, you know, easy environment. These guys were all working MBAs every time. You know, everybody was tumbled over and all that business. Yeah, they're going to have more complications, but we look at that statistic level, it's like, well, yeah, well, these guys can do it, these guys can't. We don't take in those extraneous factors. So anyway, obviously we have experimental. You know, again, does this drug work? You know, my hypothesis is we give this drug, we're going to have such and such return on spontaneous circulation, cardiac arrest. Now here's the fun part. What's this? What's the control?
You talking about control groups as
Yeah.
far as some people get it, some people don't, and you compare it type stuff?
Yeah, we got to control of study factor. Oh, I'm sorry, control the study factor.
You can't control the study factor.
Let me try to see if I can explain it.
Well, you set it up.
Yeah.
If you're doing the experiment, you're setting it up.
Yeah,
You have the control
You
to
set the
experiment
variable.
whatever you want,
right.
and you change the,
You could put a little bit of bias to it.
right.
Yeah.
Not everybody's different.
So and that's the thing. That's the thing. Actually, they'll start getting into when we talk a little bit more that kind of prevents these when we start talking like, you know, independent review boards and all this other business stuff. But observational, you know, we just watch. You know, we sit there and say, you know, again, that's that. You know, we know this group of people are going to come into this classroom about 6 o'clock-ish. All we do is watch them. Okay, this person came in at this time, this person came at this time, and, you know, it's like, well, so far consistently everybody comes in here on Tuesdays, Thursdays about 6 o'clock. So, and again, no control of the study factor. We just kind of, well, we think this is going to continue to happen. You know, it's kind of like, this is actually probably you know, I talk about like anecdotal research or anecdotal evidence. It's probably next step after something that's anecdotal. Like, for example, if I sit there and say, well, I've noticed guys who come in wearing their hats, they always seem to make about a C average. Now, that's completely anecdotal, but then I start sitting there and say, well, I'm going to start observing this now and see what the averages are. Not to pick on you. You're going to get, yeah. Okay. Descriptive. Okay, no attempt has made anything. No attempt to study effective in intervention. You know, we're just going to just call it what it is. It's inexpensive, it's simple to conduct, data's already there. Again, it's limited to the scope of applicability. I can't speak today, not the first time. And valid for only a narrow time frame. So again, we're just describing what we're doing here. Case control. Okay, observational retrospective study. Okay, now we have our two groups here. Okay, one's going to get the stuff, one's not going to get the stuff, right? You want to play with the drugs, somebody's going to get it, somebody's not going to get it. Like, some people are going to get the geezer squeezer, some people are not going to get the geezer squeezer. So, what's kind of the problem with this one too? A little bit.
Not all people
Okay.
have the same problems.
I'm going to make a decision. You guys get it, you guys don't. What's the problem there?
Bias.
Yeah, I know who's doing what. I've already chosen who's getting it and who doesn't. What if I don't like Clint? You're not getting it. I'm putting you in that group. But yeah, you got to worry about a bias factor. So, and again, we start comparing the characteristics. You guys ever do go for whatever reason go to work at Pharmaco or talk to people at PPD, that you'll hear about a lot of the stuff they'll do because they'll give them these drugs and they'll see if anything happens, the experimental drug, if not, and we don't know if it's a real drug. But those are like double-blind studies down there, especially with like one I saw was dental pain medications. You know, they did dental surgery for free, but now we're going to sit there and say we're going to give you this pain medication. They had to wait X amount of time. It wasn't working. Fine, we'll give them the pain medication we do know will work. So, cohort is that usually this is kind of more of a group of people. This could be a generation of people. You know, all people in their 30s, for example, or all people 30s that grew up in this area. We're kind of watching them on that. So usually these are attached to a longitudinal cohort study. We're trying to follow a generation that, actually want to hear a real twisted one. Look up, was it Tuskegee?
Are they going to give them the syphilis?
They had syphilis
Yeah.
for years.
Yeah.
These guys had syphilis. And this was actually, the, U.S. government. Yeah, these guys, and that was a specific group of people, African Americans in Tuskegee. And they sat there and they were given, like I said, they all had syphilis and it was passed around. They were saying, well, what's the progression? What's the progression? So, yeah. There's a couple other studies that we've done. In fact, I think they tried a nerve agent on a bunch of sailors on a ship. They just flooded it and see what would happen, kind of a thing. Yeah, it's weird. There's a lot more of these that kind of seem to, leak out every now and then. Yeah, but Tuskegee was a big one. So, kind of screwed up when you think about it. It's like, what could have been solved with penicillin in about, less than a week. These people had to live with. You guys know what syphilis does to you, by the way?
Doesn't it eventually get your nervous system in your brain?
Yeah.
And you can't think and you just lose function.
Yeah.
You lose it. I mean, everything is just gone.
All your cognitive ability falls apart. Yeah, the old syphilis.
Isn't one of the mobsters died from that in jail?
Al Capone.
There you go.
Yeah, Al Capone was one. But a lot of time, but it can actually also have parts of your body deteriorate, like your nose will fall off. Is another one. Oh yeah, you can actually get skin issues and all kinds of stuff. And like I said, was obviously a big one. You have to worry about as well canker sores, but you can get other lesions throughout your body. It can move. You all right there, man? You look like you got a spaz on that one.
No.
You don't need to run to a doctor or anything, do you?
No.
Yeah, but neurosyphilis is, these guys will go down to just babbling, just rots, whole different animal. Prince Albert and Edward was another one, actually. So, anyway, disadvantages, it's time consuming, because like I said, especially if it's a good cohort, we're really trying to follow them along. I mean, especially, their entire life. We got to have somebody keep watching that data, watch the data, and then of course loss of subjects. We're trying to capture a generation, a certain like generation X, and if we got 50 people. We saw them initially at this, in Austin, Texas. Are all 50 people going to be in Austin, Texas in the next 30 years? They're going to start splitting up and moving around and all that business. Quasi-experimental does not control the study factor. It's not randomized. This is kind of the big thing there. It's like, again, it's we know who's doing what. We're segregating you again, kind of a deal. Big thing here is experimental is be familiar with the non-blind, single-blind, double-blind, triple-blind. And the idea is we want to make this completely randomized. And a lot of times they'll just get a computer. Everybody puts their names into it, and nobody knows who's getting what or what drug is given what. They won't even label, or they'll label it or not label it, and they'll say, they can sit there, for example, like with amiodarone, they can sit there and say, yes, it's this drug, but it may not be that drug. It's actually, when you actually scan the number, it'll actually show somewhere else of what it is. But the idea is when we start putting into the double-blinded, I the researcher don't know who is the control group and who isn't. I mean, we try to take more information that we take on who's getting what. We get rid of that bias, and we can sit there and be more objective, saying, is this intervention really working or not? But be familiar with these terms.
What's a triple blinded then? Because double blinded is the patient and the caregiver don't know. But what would a triple blind be? Who would be the third?
I think it actually goes into the researcher too.
Okay.
I mean, it's you're trying to move steps back. Actually, I think a double-blinded is that the researcher doesn't know who's getting what. So I think for triple-blind, they have to move past the researcher so he doesn't really know maybe who exactly is in the control group or in any group at all, who these people really are. He just knows the numbers are out there.
Right.
Yeah. Like I said, a lot of times they'll rely on the computers to randomize who gets what. So like I said, nobody really knows. So anyway, now we're going to talk about anatomy of medical literature. A lot of times you can see in your research, you probably ran into this, is called abstracts. And they'll talk about the introduction, methods, and so forth. Anyway, with abstracts, this is pretty much, I'm going to put this information out here to bite you to come read this. And I think a lot of guys kind of ran, it's like, yeah, I got the abstract that's out there, but they want to charge me $30 to, have me read this article. That's that, trying to get you in there. That's all an abstract does. But it's just pretty much, usually it should pretty much be a summary. They usually try to restrict it to less than a page. Because, like I said, it's an attention getter at that point. So, and ideally, they want to talk about, the study objectives, they want to talk about the methods, and just real quickly, a little bit about the conclusion. But they don't really want to give you enough to not look further into the actual research. The other aspect of this, when you guys ever done research papers and have, especially with APA, I think it's with APA, isn't it? You have to do an abstract prior. I want to say it's APA style. They always want an abstract right off the bat, and then you actually support it with the rest of your research. So, and again, the abstract may reflect the author's bias. And obviously, if saying it's misleading, it's inaccurate, and may not tell the true methods. Like I said, we just want to gauge this person, say, come read this piece of material. This is what we found. This is kind of what we did. Then we'll kind of get into more specifics about it. So anyway, we go into the introduction. We talk about the brief background of the nature of the problem. For example, people having cardiac arrest. We know there's this XYZ problem about it. And our hypothesis is we come up with this, new little gadget called a geezer squeezer, and this should create, such miraculous results, and people should live, long lives even after that. And then what they do, they throw in this thing called an IRB, an Institutional Review Board. Pretty much all that an IRB does is they sit there and say, well, I want to go do some research. They have to go to an IRB board. IRB board could be doctors, it could be social workers, it could be psychologists. The idea is we want to sit there and say, is what you're doing relatively safe or should be safe to people? Is this Institutional Review Board or Investigational Review Board? Okay, that's all their really thing is making sure when you conduct this research, you're not doing anything unethical and you're not intentionally harming somebody. So, methods. Ideally, the methods, whatever methods they come up with, we want to be able to duplicate at any time and get more or less get the same results. So, and again, the study should decide, hey, when we decide to study, this is going to be more of a prospective study. We've got this controlled, blinded group. It was completely experimental, and this is how we're going to get the information. So, pretty much, again, like I said, we're talking about how the study was designed, how we're going to get the information. These are what we did all the way, down the line here, and so forth. Describes the study sample, the people there, the inclusion-exclusion criteria. We may sit there and say, everybody in this classroom between the ages of 18 to 25. And if you're if you were in that age range, if you had, let's say, AB blood, then we had to exclude you there. But we wanted people that were just O negative. So, and again, the statistical analysis, so forth. Results, describe the sample size, what's the data, did we find any significance? And basically, when you talk about the peer review, we want to sit there and say, really did everything that you did, was it really up to, whatever standard you're doing it to? It could be whether it's the psychology community or psychiatry community or medical community, depending what it is. Say, okay, yes, you're consistent to the way we approach things and the way we did things. This looks legit, is all we're trying to say here. Any questions? Am I going too fast, too slow? Okay. Discussion at the end. The author may present, bias may be presented and discuss their own interpretations. It may compare this to other study, or you'll actually see at the end will warrant further study. All studies always seem to throw that at the end, will warrant further study. And usually they'll talk about their strengths, limitations, and things that they ran into as they're going along there. Because everybody's going to run into that. It's not going to be that crystal clear. It's like, yeah, it looked good until we ran into this problem, because not all problems are foreseeable. So, and again, conclusion, summary of the article tied together with all aspects to support the conclusion. And hopefully, a lot of times, they will try to put together a study. Obviously, they want to study something that's going to support what they're doing. It's very rarely you'll ever see something that, it's like, yeah, we did the study and it totally tanked. But we're going to publish it anyway. Usually, they kind of avoid that. unless for whatever reason they've got their attention, somebody's attention, they're like, no, we really want to know how this is going to turn out. You're not going to kind of snuff this one. So types of literature, okay. Big thing with this, like with your books there, understand this develop within need of the academic environment, okay. The thing here is like with this stuff, we want to get you base knowledge to build off and go with. You know, we're not when you go down, year and a half later, and we start talking about what procedure may be effective or whatever. Then we start getting into more theoretical medicine. We're not really too concerned about that right now, but we're kind of geared to giving you the book, giving you a foundation that you can stand on and say, okay, I know this is what is accepted, this is what is expected, and so forth. Again, a lot of these are curriculum directed, and big thing is obviously national standard curriculums, and pretty much everybody goes by. We can't seem to get around that. But as you can see here, often lacks supporting documentation for statements. Some actually books are pretty good about that. They'll actually put little reference footnoting to say, hey, go look at this if you have more questions about that. And the quickly outdated, so-so. They always seem to come up with a new edition every year. It doesn't mean they always put everything. I don't know if you ever noticed this, but a lot of times something like the 6th edition is just the same as the 7th edition, except the colors are prettier. It's not like with this when they came out. It's like, yeah, the 2000, the new edition of that said, yes, we have the 2010, AHA guidelines incorporated. That was probably more significant of more update out of any of it. But a lot of times it's, these guys are in the business of making money.
Marketing scheme.
Yeah. So, it's if it's a truly, truly dynamic, then yes, you'll probably see something or something groundbreaking. A lot of times, relatively the same. Trade journals. How many people read GEMS? Journal of Emergency Medical Services? Yeah, that's a big trade journal. Another one is, was it EMS World? I think another one that popped up. Yeah. But these are pretty much, like I said, non-peer reviewed. So it's kind of like you can kind of talk about, whoever can talk about whatever, really. It can be editorial, they can soapbox or discuss, what's going on in this system versus that system. Just talk, again, trends and tools. Like I said, it's just kind of more, network with what's going on with the rest of the, EMS community per se. Provide CE, continuing education. A lot of times they'll have a little thing up there, and usually like half a CE for taking the little quiz or something like that. The other ones you got to worry about, the scientific journals. Like I said, it's research directed. Like the big thing here is we got that independent review board. Again, it's looking at this and says they're saying, yes, we're doing what you did was not harming other plants and animals and every other thing that smiles in the world. And then, like I said, it's peer reviewed. Like I said, people in that community, so they're saying, okay, yes, this makes sense. This is consistent to what's really going on, and your methods were very acceptable. Instead of saying, I came up with this, new method that's completely off the wall for testing this, that, and the other. These guys, we want to make sure everybody's on the same page and so forth. Websites. Websites you got to be careful with. Like, how many of you guys looking at Wikipedia?
I know some people can't you just make something up?
Yeah, you can just edit
You really
it.
can.
Edit it.
Yeah, you really can. The thing about, a lot of people actually, I've seen people put in research papers, they'll actually put in Wikipedia as a resource, and it's kind of good and bad because, unfortunately, there was that guy, it was about a year ago, he said, oh yeah, I've been putting up false stuff on Wikipedia for how long? And he really kind of badmouths everybody else who actually is trying to put a very reasonable database up there. The thing is, if you be careful, the advantage of this, if you ever do look at Wikipedia and you find something that's interesting, nice part about it, they usually have footnotes that say, here's the original website, and it'll actually take you to more of a legitimate website. It's kind of a little FYI. So, but yeah, it's the thing about with websites, it can be, be very misinforming, put whatever you want. Like, for example, like I've ran into this one. Actually, we had to create a little bit of policy on this. We're running a lot of times when you can challenge questions. If you can say you find this an acceptable, piece of medical literature documentation of such, we can take your argument consideration, give your point back, right? I had people finding. I remember it was like over a couple drugs. People were finding information on this medication of some place out in the UK that was kind of just north of York, and I mean it was just like, who are these people? But they could just were writing whatever they. It's like, well, you understand, I did find something on the internet, and I was like, no, we're going too far. If it's something like drugs.com or the U.S. Pharmacopoeia or a website like that, yes, I can give validity to that. But like I said, you can find whatever you want on the net. So, serve carefully. Online journals, again, they should be reviewed. Usually, a lot of times, what's it like? Journal of American American Medical Association. Usually, what they print and what they put on the website is the same thing. It's just whether you want to get the hard copy or the electronic copy. So, other online databases. If you guys ever go on to the TC Library website, you'll find a whole bunch of those. Actually go to databases of other colleges. I was actually playing in UT Austin's database, looking up for a project I had to do. So there's a lot of legitimate, and like I said, a lot of times when we start going through more of an academic institution, they don't want to put just kind of random websites, because then they start looking like they're just putting up random trash websites, and they don't want to lose their credibility. So that's kind of the advantage of there. Any questions on that?